Why don't we talk openly about something that impacts half the population? Why do so many women suffer in silence through a transition we should all be better prepared for? For too long, perimenopause and menopause have been misunderstood, stigmatized, and overlooked. Millions of women experience menopause, yet the knowledge gap is staggering, the support often lacking, and the conversation whispered, if it happens at all. But here's the reality. Perimenopause and menopause aren't just women's issues. They're human health issues, touching families, workplaces, relationships, and overall quality of life in profound ways. Let's get started. Welcome to the Health Exchange. I'm here today with Dr. Jamie Rutland, and also joining us is Andria Terrazas, a nurse practitioner and owner of Verve Health. Thanks for being with us.
Thanks for having me.
So we're going to talk about a subject today that is under-discussed, often viewed as taboo. But before we dive into it, why don't you tell us a little bit about yourself and your background?
Yeah, so I started in primary care, family medicine, where I quickly caught on that traditional healthcare often leaves patients feeling unheard of and unseen. I mean, it's really quick to have a very well-established appointment within 15 minutes to go over all the patient's concerns, come up with a good treatment plan, review the treatment plan, talk about follow-up. And so with this thought, I felt like if we could create a space where patients feel heard and seen, there's good communication, and they have enough time, then maybe we would have better patient outcomes. So with that thought in mind, and then with help of my husband, who's also a nurse practitioner, we decided to open Verve Health, which is an integrative medical practice where we treat people as a whole. So I specialize in perimenopause and menopause care, PCOS, thyroid optimization, testosterone replacement therapy for men, and weight management. So Verve Health, our mission is really to bridge this gap that traditional healthcare is kind of missing out on and really help patients feel heard and seen and like themselves.
That is exactly what we need. I love that you chose to take your career and specialize in an area where women feel like they're not seen.
Yeah.
And now they have a place that they can go to and talk about their signs and their symptoms, and you provide that safe space.
Yeah. I mean, it's so rewarding, and it's working. It's working well.
So we know that 25 million women go through menopause a year.
Yeah, it's a lot of people.
And 90% of those women have no idea what the signs and symptoms are, and they say that they were never educated on it.
Yeah.
Why do you feel that women are they're not informed? They don't know about it.
Yeah, I think we have to take a step back because it stems from both the public and also the medical providers. So in 2001, there was a study that came out by the Women's Health Initiative that kind of caused this widespread hormone replacement therapy panic. And it caused the providers to feel afraid to prescribe it. And there was a lot of media surrounding it as well that then made our patient populations afraid to even start it. But fortunately, not too long ago in 2022, the Women's Menopause Society, formerly known as the Northern American Menopause Society, came out with a study reviewing that Women's Health Initiative study and gave us more data to support that hormone replacement therapy is actually safe. And it gave us a guideline on how we can treat people.
What were the consequences in that original study? Why was everybody worried?
So what the concern was, it had put this fear that if you treat women with estrogen or progesterone, which is what we're supplementing in perimenopause and menopause, they're at an increased risk for stroke, heart attack, breast cancer. Mm-hmm. And it kind of put this image out that if you give women these hormones, it's going to result in that, which we've learned is not necessarily true. That risk is a lot lower than what we thought it was before.
We're hearing too that, I think I read somewhere that 70% of women have signs and symptoms of perimenopause or menopause, but it's not being diagnosed or it's being misdiagnosed.
Yeah. So within the symptoms of perimenopause and menopause, there's a lot more to it than the general things that we hear about, which is hot flashes is the most common one, and mood swings. There's a lot more symptoms behind that. And so what's happening is, with the lack of education for providers, and then also with there being so many symptoms, it's not unheard of for people to be getting diagnosed with depression, anxiety, ADHD, fibromyalgia, adrenal deficiency, when really it's a hormonal issue. It's perimenopause and menopause.
Are your patients coming to you and saying that they're seeing multiple providers before they're actually getting diagnosed?
Yeah, they are. And it's this back and forth thing. And I mean, I wasn't a great menopause provider to start off. And the reason being is because I was afraid. I wasn't sure how to treat it because I didn't really quite get the proper education. And when I'm in primary care, I mean, normally the thought is if someone comes in, they think they're at menopause or perimenopause, you send them to gynecology. And then they go to gynecology, and a lot of gynecologists are like, no, it's not safe. And then they punt back to primary care. And then they're having to go to outside sources to find someone to listen to them. So yes, lots of providers before they come to me or somebody else that will hear them.
So we spent a lot of time talking about menopause, saying the word menopause, perimenopause, but I think we should define it first. You want to define it for us?
Yeah. So menopause means that a woman is no longer ovulating and having a period, essentially what it is. So menopause is defined by that one day where you have had 12 months without a period, okay? Perimenopause is the transition between pre-menopause and menopause. So in perimenopause, a woman is going through these hormone fluctuations. What hormones am I talking about? Estrogen and progesterone. So estrogen and progesterone play a major part in a woman's menstrual cycle. When they enter perimenopause, those hormones kind of go, and this is how I explain it to patients, is it goes through these two cycles of, oh, we're gonna make these hormones, we're making these hormones, and then it's like, no, I'm not gonna make them. And then it goes back and it makes them. So it's this perpetual cycle, which causes your hormones to jump erratically up and down. So that's that transitional phase.
I like it explained this way, where you think of menopause as a day, because I don't think that patients really think of it that way. Menopause is one day where essentially you haven't had a period for 12 months. And then anything prior to that we consider to be perimenopause, anything after that post, right?
Yeah.
Okay.
Yeah.
You know, the way that I explain it to my patients, and again, as a pulmonary critical care doc, as an internal medicine doc, I got to explain it sometimes before I send them off. I always say, listen, if you're eating something every single day for 40 years, you're eating the same thing every single day, and then it's taken away, like, you're going to notice.
Yeah.
That's how I explain menopause to the females in my clinic.
I think that's a great way to explain it because it's true. It's something that your body has been doing for so long, which is ovulating and having a period. And then all of a sudden it's like, I think I'm going to do it. Oh, I'm not going to do it. And then you finally hit this point where it's not doing it anymore.
I think we should jump into the symptoms because I know people want to know, what are they going to experience when they go into perimenopause?
So the symptoms with perimenopause and menopause are very similar.
Okay.
I will say that with perimenopause, it can be a little bit more erratic because remember I talked about those big hormone fluctuations that are occurring. But like I keep saying, there's a lot of them. So we know the common ones. We know hot flashes. We know mood swings. So let's dive into it a little bit more. So vasomotor symptoms are hot flashes, night sweats, and heart palpitations. And then there are mental cognitive symptoms. So increased depression, worsening anxiety, forgetfulness, fatigue. And then there are the genitourinary symptoms, which is vaginal dryness, painful sex, and increased urinary tract infections. And then the not so common ones are itchy ears.
Okay.
And joint pain and constipation.
One of the things that's really interesting that I was reading about for perimenopause was all of the learning disabilities and the forgetfulness was perimenopause, but then it kind of stopped. And then in menopause, you kind of got your cognitive function back. It was just really interesting reading about that.
Yeah. And I will say that when women cross that threshold into menopause, the symptoms that I see people complain about the most is more the genitourinary ones. So the vaginal dryness, the painful sex, and then the frequent UTIs.
I'm going to be honest. When you say this list of symptoms, as a woman, I feel like a lot of women are sitting there and they're like counting on their finger how many they have, right?
Yeah.
Like, especially if you've had kids or even
Right.
if you haven't. But a lot of women can relate to having those symptoms. So how do you know that it's perimenopause and not just, you're having depression or you're having...
How you know if you're in perimenopause or menopause, I would ask your parent, your mother, when they had menopause, because that might give you a ballpark.
Okay.
I would also just pay attention to how you feel. Now, you mentioned that if you're going through the same thing in your body for so long, you'll notice a shift. You'll notice a shift. And not for everybody will have the classic symptoms. Not everybody is going to have hot flashes. Actually, a lot of women don't in perimenopause. It's more mood disturbances, fatigue. They're not getting good sleep. They feel a little bit more anxious. They feel like they're snapping at their kids more than they used to. So I would just really listen to your body. Like, when your body, something's not right. And then talk to a medical provider about it.
One of the things that's really interesting, and we've harped on this before, is when you look at your body, your cells, every single cell in your body has a certain type of receptors, right? And so you have all of these molecules floating around in your body. You've got cytokines, you got chemokines, you got hormones, all kinds of things that are just floating around, binding to their receptors, activating certain things, activating certain actions, activating the way you think, the way you move, how you act, how you respond. And when you're going through perimenopause and menopause, you have a lot of these molecules that are just no longer there, and they're affecting you in ways that you're just not used to. And so one of the things that I was reading about with perimenopause versus menopause, and we were talking about depression, because in some of these studies, they would see individuals who developed depression, and they thought, oh, is menopause causing depression? Well, generally speaking, in perimenopause, you're going to see people that might be more anxious, more agitated. And if there's no history of depression, it's less likely they're going to have depression. But typically speaking, it's not that menopause makes you depressed, but if you have that history, you might become more depressed. Is that accurate?
Yeah, absolutely. That's accurate. I think the other thing to consider is if you're going through this transition, you don't feel like yourself, and then you go to a provider and they're not listening to you, you're probably going to feel pretty crappy about yourself and about what you're going through and not feeling heard. So I think it's multifaceted, with your body going through that transition and feeling kind of down, and it maybe not really being depression. And then you're trying to talk to a healthcare professional, somebody that should, hopefully listen to you, and you're not being heard. So I think it's a compounding effect.
We know that there's long-term health implications for menopause as well. Can you touch on some of those?
Yeah, so when your body is going through this transition, so you're not making as much estrogen, you're not making as much progesterone, there can be some long-term risk. So the biggest one is a reduction in bone growth. So all of our lives, we chew down bone and we build up bone, right? A woman, when she is the age of 35, when she turns 35, her body is not going through that regeneration process as quickly as it was before. So it slowly starts to go down.
I'm counting the years.
Starts to go down. But then when she hits perimenopause and menopause, it goes, it drops. And so what the concern is the risk of osteoporosis. Now, why are we concerned about bone health? Why am I concerned about osteoporosis? Because I'm worried about frailty. I'm worried about these women who try to move or get up from a chair and they fall and break their hip and they have an osteoporotic fracture because their bone is not as strong anymore. So hormone replacement therapy actually can help with that. It is FDA approved to help with bone loss. And then the other thing on top of that is our musculoskeletal system is very much intertwined. So the next thing I'm worried about is muscle. So if your bone is a little bit more frailer, your muscle mass is probably also going to go down too.
And muscle mass goes down 10 to 15%, is that correct?
Yes. So within that first 10 years of menopause and with aging, on average, a woman loses 10 to 15% of their muscle mass.
It's a significant
It's a
amount.
lot.
Yeah.
That's a lot of muscle. And fat gets redistributed as well, right? Fat becomes more, adipose becomes more central as opposed to peripheral, which increases the metabolic disturbance risk, right? So increase in diabetes, obesity, things of that sort.
Yeah, so worried about insulin resistance. So worried about women's insulin not breaking down sugar the way it's supposed to. So now we're having an excess amount of sugar, which is going to increase their inflammation, which is also going to worsen their hormone production as well. So it's all interconnected.
Yeah, it's
We
all
know it
interconnected.
affects the heart too, and we have to touch on it.
It does.
It does. It makes
does.
your cholesterol levels go up. It puts patients at a higher risk for heart attack and stroke.
Yeah, it does. And hormone replacement therapy
Helps
can
with
help
that too? Wonderful.
Can help with that.
Yeah, your LDL goes up, your HDL comes down,
Yep.
as you know,
Yeah.
increases that risk.
So, with so many symptoms associated with menopause, how does a provider diagnose?
So there is no lab test that tells you, yes, you're in perimenopause. Yes, you're in menopause. It doesn't exist. So you cannot do it by lab tests alone. It's based on symptoms. It's based on their age. It's based on their medical history and their family history. That is how you diagnose it.
And medical history is extremely important.
It is.
Right? Having, my wife go through her own cancer issues. I mean, there are lots of different cancers that you have to pay attention to, lots of different therapies that you have to pay attention to understand if people can go into menopause maybe sooner than expected, and how to manage those symptoms. So that's got to be really difficult for you sometimes, right?
It is. I mean, there's the clear-cut examples. If someone's had their ovaries removed, they will throw them into an early perimenopause and menopause, which you can treat those people with hormone replacement therapy. But there are other things like stress factors. If someone has been under a lot of chronic trauma and stress, that could induce an early perimenopause potentially. Also, depending on what kind of medications they've been taking is a really big factor to consider. And if they have a familial history of clotting disorders, then maybe we're concerned, and maybe we don't want to do estrogen, because estrogen can increase the risk of blood clots.
I'm picturing from the patient's perspective, patients who walk into their primary care provider's office and they have 15 minutes with their primary care provider and they want to be able to discuss menopause. It just feels like that's not you got to ask a lot of important questions from your standpoint.
Right.
You're in a specialty, but most people, I assume, are first having this discussion with their primary care provider.
Yes.
Yeah. So how do you inform a patient to be able to walk in with confidence to their primary care provider and have this discussion?
Yeah, so there are some things you can do to arm yourself with information and to feel prepared when you enter that appointment. So the first thing I recommend is schedule an appointment in the morning. So you're got the provider, fresh in the morning, they got their coffee, they're not as, tired out from the day. But also consider being fasted so that if they order lab tests, you can get those done right away. The next thing is write down your family history and personal history of any conditions, any medications you've taken, your surgical history, if your mom has had diabetes or hypertension or anything like that, so that when you have that discussion with the provider and they ask you that question, you're like, here it is, it's right here. And then the next thing I would say is look a little bit into the medications and maybe think about what you feel like would be the right fit for you. Making suggestions to your provider is always a good thing, because it also can get the provider thinking that this is what the patient wants, and maybe this wouldn't work, but this would. So, and then also I would say, take a breath. You know your body best, and you know when something's not right.
I love that.
Earlier, you were talking about traditional medicine doesn't have enough time to be able to see or spend time with these patients. What do you do in your clinic to be able to have that time?
Yeah, so at Verve Health, I have the flexibility because I'm not accepting insurance.
Yeah.
Because insurance is they're not going to cover that. And so by removing the insurance and having a cash-based practice, a membership-based model is what I do, I'm able to give patients the time they really need to sit and talk to me. Because healthcare is just beyond someone's signs and symptoms and their diagnosis. It's also about their community, and do they have a sense of community? Do they have friends? Are they decompressing? Are they doing things for themselves to rebalance themselves out to deal with the stress of everyday life? And you really can't get to know people if you have, less than 15 minutes, because by the time you room the patient and everything, it's just not possible.
That's a really good point too, because women who are going through this need to feel like they have a sense of community. I think that carries a patient through almost just as much as the treatment options.
Yeah.
Speaking to that, let's jump into the treatment options. What are the options for patients who are going through menopause? I know hormone replacement therapy is kind of top of the list.
Yeah. Yeah. So the hormone replacement therapy is the first thing you want to consider as long as there's no contraindication. So there's not anything in the patient's medical history or any medications they're taking that would make it not safe for them to take those medications. So the two main stars of the show hormones are estrogen and progesterone. So estrogen is good for women who don't have a uterus. You can treat with just estrogen. But if you give a woman estrogen that has a uterus, it's going to thicken their uterine lining, which is going to increase their risk of cancer. So the way that you combat that is treating them with estrogen and progesterone. But progesterone sometimes is great to use as a alone therapy in perimenopause, because when you look at the hormonal pathway where our hormones are made and the flow of that, it starts with pregnenolone and DHEA. And pregnenolone turns into progesterone, and then progesterone has a downstream effect where it then creates estrogen and testosterone too. So if you treat women with just progesterone, a lot of times that will alleviate most, if not all, of their symptoms. And it's safe and it works.
Timing on this is important, right? Because I was reading that when you start these medications, the age specifically kind of changes the risk factors for the patient.
It does. So if a woman is over the age of 60 and they're 10 to 15 years post menopause and you start them on hormone replacement therapy, the risk of blood clots and dementia outweigh the benefits of improving their symptoms.
Oh,
so that's not an ideal time to start hormone replacement therapy.
What would you say the ideal age is?
So the ideal age is below the age of 60, 10 years pre-menopause. The benefits of helping with those vasomotor symptoms that I keep talking about and also helping with bone loss, those benefits outweigh the risk of any potential complications.
When you say hormone replacement therapy, you don't mean topical hormone replacement therapy. You mean systemic hormone replacement therapy, right?
Well, not necessarily.
Okay.
So there's a lot of different routes that you can take these medications. You can do oral, you can do transdermal, which is a patch that you wear for a week or 2 weeks and take off. You can do creams, and you can also do vaginal insert rings or suppositories. So depending on what we're treating, will kind of lead into what kind of treatment we might be interested in. So if we're really concerned about hot flashes, a oral medication of estrogen or a transdermal, those tend to treat those vasomotor symptoms a little bit better versus a vaginal cream or vaginal insert. If we're concerned about vaginal dryness and increased urinary tract infections, then doing just a low dose vaginal cream or a ring works a little bit better.
If a patient's having both of the symptoms, can you use two different types of treatment options?
You can. Yeah, yes, you can. That's a misconception. So you can do oral estrogen and progesterone, and then you can use a low-dose vaginal cream. You can do it daily or just when you need to. It's very customizable, I would say, with a topical cream vaginally, just to make it work for what your symptoms are.
So if your spouse has female reproductive organs, and they're going through this, what can you do to support? And do you partner with a therapist? Do you partner with somebody that can help somebody? Like, I'm a husband. I'm almost 44 years old. My wife actually takes, an estrogen inhibitor right now. And so how do I best support her as she goes through almost perimenopause because of therapy?
Well, I would say at the top of that, you already are helping her because you're already thinking about it. You're already thinking about the impacts that has for her. So you've taken the first step. The second thing I would say is just hold space and patience, because it is really ravaging on the body, going through those hormonal shifts. And so I think just having a partner that maybe can step back and not take it so personally if they're lashing out at you or lashing out the kids or the dog or the cat, and go, it's just, my partner is going through this shift, and just knowing that and holding space for that is so helpful.
So you're telling me it's perfectly safe to tell the kids, mom's going through menopause.
You know what it is. And you know why? Because you're having the conversation of what perimenopause and menopause is, which we should talk about it in the household, just like how you talk about puberty with your kids, right? It's just as common as perimenopause and menopause for women. Every single woman is going to go through this hormonal shift in some way, right?
Mm-hmm. We should talk about it in the home, in the community, on social media. Like, that's what needs to happen.
Yeah. But then to add to that, finding a female therapist, I think, can be really helpful. Couples therapy, of course, is great, but talking to somebody that maybe has a little bit specific knowledge of what that shift feels like and what it looks like and how a partnership can work together through that could be very helpful.
So if a patient presents to you and you have this discussion about hormone replacement therapy and they say, I don't know if that's for me, what other options are there for those patients?
Yeah, so you do have a couple options. You can do antidepressant medication, serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors in lower doses can help with hot flashes. And they can help if somebody already has depression or anxiety. It can help with alleviating some of those symptoms of dread and anxiousness. But the next thing you can try is gabapentin, which is actually a nerve pain medication, but it has been shown to help with hot flashes. And it can also help with sleep disturbances like insomnia and it's kind of an off-label use, it causes sedating effects. But I would note with gabapentin, it can cause weight gain. So for women who are already maybe feeling a little insecure about gaining weight and having a hard time losing it,
gabapentin may
not be the right fit. And then next to that there is a DHEA vaginal insert you can use for some of those genitourinary symptoms that I keep talking about, and that's considered a non-hormonal therapy.
So what you guys are hearing, again, is you're hearing lots of different options in terms of therapy, which really tells you that what women are going through, or what people with female reproductive organs are going through as they gain life experience, as I like to say, is completely natural, scientific. It happens to every single one of those persons as they're going through it. I mean, this isn't something that, like you said earlier, you feel lonely or it's just you. It's not. There's a million different people who are going through the exact same thing because of the molecules that just aren't as balanced as they once were because of natural things that happen in your life.
So I think, too, we need to talk about the fact that lifestyle modification efforts, right, really can help women that are going through menopause, making sure that we're still focusing on exercise, eating a healthy diet. There's also a mental health component. So having a counselor or someone to talk to about, I think, is crucial.
Yeah, absolutely. Some things you can do as a woman to help with your diet to support the transition you're going through. I would say eat a low-carb diet. A low-carb diet is going to decrease the amount of sugar that your body has to break down, which is really going to help with that potential insulin resistance. And then also not having as much sugar in your body is going to help with inflammation, and it's also going to help with your hormone dysregulation as well. The other thing you could do is make sure you're eating enough protein. So on average, a woman is supposed to eat 30 grams of protein per meal per day. That's 90 grams of protein in a day.
I need to work on that.
It's hard. I struggle with it. That's a lot of chicken,
That's a lot of chicken.
But eating enough protein is going to help with feeling fuller quicker. It's also going to help with maintaining that muscle mass. So it is worth it to really try to reach your protein goals.
You know what was crazy is I read this study, a couple of them, that talked about physical activity in menopause. And it was like moderate to aggressive physical activity actually worsens the symptoms. It was absolutely, I was like, what? And I read a couple of studies that way. Is that surprising to you too? Like, how do you counsel the individuals that come to your clinic seeking advice when they ask you, like, should I exercise? Are there specific things that you say? Like, what do you say?
Yeah, so there's a couple things there. So moderate to severe activity can be unhelpful in menopause if it's causing too much stress on the body. But that's not the case for everybody.
Right.
So weightlifting and resistance training, if you're going through perimenopause or menopause, or if you're just a woman in general, you have to be doing it. Because remember, I talked about the risk of osteoporosis. If you don't put any pressure on your bones to signal them to create more bone, that's not going to help with that bone loss. So you have to be doing some kind of weightlifting or resistance training. Now, if that's daunting, which it can be for a lot of people, you can get a weighted vest and just go on a walk. It's enough stress on the bone to help continuously regenerate that muscle. But some other things to consider with that is if high intensity workouts are working against you, find something that's lower in intensity. So maybe a Pilates class, which is great because it focuses on those minute muscles a little bit more, which will help with the sarcopenia, with the muscle loss that we're also concerned about. And then yoga's great and it's accessible. You can find YouTube videos online. You can do it at home, and it also will kind of make you feel more balanced and centered.
So elephant in the room. You've got a couple. Let's say you got a traditional couple, right? And as we're aging, we know that our hormone levels are coming down. Sex is probably coming down too. What about women who, and men for that matter, who are developing this hypogonadism, who do not have that libido but still want to enact in sex? Like how do we approach that? How do we deal with that, right? Or you have a spouse that's going through it, and like, how do you deal with that? What's the best way to deal with that, or what would you suggest?
Yeah, I mean, just because you're getting older doesn't mean that you can't enjoy sex anymore. I mean, sex is a really important part of the human experience, I would say, and especially when you're in a relationship. And we want to be able to keep doing that. What I tell people is there's a couple things you can do. So for women specifically, if you're having vaginal dryness because you're going through perimenopause or menopause, you can use a lubricant and it will work really well. Some tips, make sure that it's water-based. Make sure it doesn't have any dyes, colors, or flavors, because that will cause irritation in that area.
There's lubricants with flavors?
Oh, yes.
I'm serious.
There are.
She's right here. She's the
I don't
first one
know if
ever
I
told
should
me.
be like happy or sad that you don't know the answer to that.
Well, she's the first one ever told me that lubricants have flavors. I had no idea.
There's all different kinds. Yes,
Are
they
you
come in different
there's
flavors. Yes.
Give me a flavor.
Strawberry.
Oh my gosh.
Right.
First and foremost.
They both said strawberry.
You know what's
That
up.
is very scary. Oh my, I swear I had no idea about this.
Oh,
That's
goodness.
interesting. Okay. all
Yeah,
right.
yeah. So just be mindful about what you're putting in your privets, as I always
Yeah.
say. because your vagina is a self-cleaning mechanism, and so it'll clean itself out, but don't use any weird powders or create like washes or scrubs that are supposed to balance your pH. No, none of that.
No
Like,
red dye in your vagina.
no red dye 40 in your vagina.
Oh, goodness.
But yeah, I mean, we're laughing about it, but it's the reality of it. Like that's the thing, is we got to think about this. We got to talk about it.
Well, and to circle back and bring a little seriousness to it,
Yeah.
because it is a really important topic. I think that women get to that age, and correct me if I'm wrong, but I think that there's like a misconception that women just don't want to have sex anymore. And that is not the case.
It's not the case. And I'll tell you a story. So I had a woman come in, and she was in her early mid 40s, and she was so distraught because she said she had this great sex life and she's super attracted to her partner, but she didn't feel like having sex anymore. And it was starting to cause this strain in their relationship. And she thought that maybe there was something wrong with her, like something wasn't working the way it was supposed to, something wasn't. She was going through perimenopause, right? She was having a hormonal shift. So we started her right away I did oral progesterone, which helped with her sleep. And then we gave her a low dose vaginal estrogen cream. And within a week, she called me and was like, girl, I don't have that problem anymore. It's fine. I feel great. My sex drive is up. I don't have vaginal dryness, so I'm not having painful sex. And that's the thing is, I know this is so scary. We're talking about all these different hormones and all the doom and gloom of being a woman and going through these transitions, but these things are fixable. They're fixable. There's low risk and they work well. You just have to find somebody that will listen to you and work with you and grow with you and find those solutions.
So obviously I'm a physician and I know some of these things, right? But how do you as a spouse say, hey, do you think maybe you should try XYZ, or maybe you should see this person, or this person's not thinking of, like, how
Not
do
like
you,
that.
right? How do you, no, I'm just saying, like, how do you, that's why I asked a question. Hey, listen, this flavor lubricant, okay, over here, you guys, like, get out of
They
here.
have numbing ones too.
Right.
Let's teach Jamie how to come at this much softer.
Let's do it. Let's role play right now. Let's role play right now. So you be me.
Okay.
You be my spouse.
Yeah.
Let's just pretend.
Yeah.
Not to say, listen, I'm not saying like we need to have this conversation at all, babe. But I'm just saying let's play a role as like two people who are having issues. Like, how do you as a spouse support it and say, hey, listen.
Yeah.
Women are applauding right now because this is what they want to hear.
It is. It is. So this is how I would approach it. At least this is what I want to hear.
So this is your wife and your husband.
Okay.
Okay.
Hi, wife.
This is I'm the wife.
Yeah.
You're the husband.
No,
I'm
she
the
is
husband.
You're the husband.
She's
Oh, and you're
teaching.
gonna. Okay, I'm ready.
I am a husband.
Yeah.
But in this scenario.
Okay. Savannah, you know, you're so beautiful and smart and intelligent, and I love spending my life with you. And I love being intimate with you. Like, you're so sexy and you make me feel good. But I've noticed that I don't think you're enjoying it as much, or maybe you're not wanting to do it as much. And because I know this is an important thing to you and it's an important thing to me, I'd like to know how you're feeling, and if that's true or if it's not true, and if there's anything that I can do to make it more enjoyable, or is there anything we can try, or do we need to book an appointment so maybe you can talk to a specialist? I mean, there's no pressure, because I know that maybe this feels like a lot that I'm telling you right now, and I don't want to make you feel bad about it because I love you, and no matter what, I'm here for you. But is this something that you've noticed or you're having a hard time with?
I don't get the kids. I'm kidding.
Oh my gosh. I almost started crying through that. If anyone spoke to me that way. Can you do that? Can you execute that?
You want to try to execute it right now?
No. But do you think you could?
Do I think that I can execute what she just said in the manner and cadence in which she said it?
Yeah, be honest.
I mean, of course.
That was beautiful. I think
you.
that is exactly what women hope that their spouse can
What
say
was
to
your
them.
favorite part about that execution? What was your favorite line?
It wasn't the line. That's the thing. It's not necessarily the words that are coming out. It's the emotion and your presence and you holding space for me and saying that I see what's going on. You're safe. I love you. I'm happy to, like, I want to be intimate with you. What can I do to support you?
I like the way
And
you
just-
said holding space.
Yeah, just coming at it from that softness is.
But it's not accusing you either of like your body is doing something wrong or something's wrong with this. Like, I'm fine.
because it feels that way.
Yeah.
You feel like something's wrong with you.
Oh, for absolutely. Yeah, that's how patients feel when they come to me. It's that common thing of what's wrong with me. Is it all in my head? It's like, it's not in your head. You're going through this transition and it's causing all these symptoms in your body and you feel like you're going crazy, but you're not crazy. It is fixable, and it happens to every woman, you know, no matter, again, every woman will experience this hormonal shift in some way in their life.
So we need to change the narrative. You know, it's mind-blowing to me that at this day and age, this conversation is still so taboo. Our moms aren't having it. Our grandmas weren't having it. How do we make this conversation more approachable?
Yeah, I mean, do you guys have tips? Because it's a hard thing.
I mean, we started right here,
Yeah,
right?
we do. We started here.
I think incorporating the spouses and making this a family natural progression as we all, you know, go through the natural stages of life there are certain things that are going to happen to both of us. And I think that if you can set it as a family conversation, then it becomes healthier to talk about from both sides. Because I can imagine, like, I have exposure to thinking about this because I'm involved in healthcare. I have exposure to thinking about this on a daily basis. Somebody is going to say the word menopause to me. There are men out there who are not exposed to it at all, and their spouse, will not approach it right with them. And so I think making that aspect more comfortable so they can talk back and forth, I think that's where you start. I don't know, because it seems to me that you two know about the subject. You've thought about it.
Yeah.
You are an expert. Do you think that because of your expertise, that when you go through it, you're better prepared?
Yeah, because it's not a big, scary unknown. Because perimenopause and menopause is as common as puberty that we go through in adolescence. So you're talking about like this family dynamic, and we're talking about it at home. You talk to your kids about puberty, right? It's maybe, it could be a family discussion, but it's a discussion that you have to prepare them for the changes that their body is going through. Why don't we have the same discussion about the menopausal transition?
I got two girls.
Why do we not?
I got two girls. Like, I'll be honest with you guys. I haven't talked to my girls about puberty. Like, they've gone through it. Like,
they're in it.
My 12-year-old's in it. Like, but that has been a discussion between her and her mom. Like, in terms of her body's changes. Because honestly, like, as a guy, like, I really feel, and I shouldn't feel this way, because as a physician, I have to be in it, right?
Right.
But as a guy, I really feel out of place isn't the right word. But when I am speaking about things like that, I want to come from a place of experience somewhat. Yeah, my mom went through it and I remember it, but like, I want to come from a place of I don't want to mansplain it. You know what I'm saying? Like, I don't like that.
What about the emotional? Like, I'm assuming when you're saying this about your daughters, you're referring to their menstrual cycle and this, that, and the other thing. But what about the emotions that your girls are going through? Because you're seeing that in the house, I'm sure. The mood shifts.
Yeah.
So how do you sit down and have that conversation with them so they feel like dad knows what I'm going through and you can meet them there?
How do I have a conversation with my kid about that?
Yeah. Would you do that?
Yeah, of course I do that. I did that all the way home from Temecula yesterday for 45 minutes or an hour and a half, however long it took. Like, we had a long conversation. Yeah, you have those kinds of conversations. Of course you have those conversations.
I think what I'm hearing is you feel like you're almost not invited into the space because you don't have those parts and
Bingo.
You're not going through it, right?
Because when your kid says to you, Dad, like, you don't have, you don't have a vagina, or you don't have ovaries, or you don't have breasts, Dad, like, you don't get it. Like, it's kind of like, well, damn, she's right,
Yeah.
But that's it. You're right. I don't get it. But I love you and I care about you. And I know this is impacting your schoolwork, or it's impacting the way you talk to mom or your sister. So I love you and I want to support you. And I want you to know that I know you're going through this and it can be hard sometimes.
You should apply for the position of dad.
Well,
I'm not trying to tell you how to be a parent at all. I don't have any kids, but
I'm picturing a mom hearing, her husband say that to the kids. And that's giving her a door too, to be like, maybe I have some things that I want to talk about as far as menopause and perimenopause.
Humans want to just be acknowledged.
They do.
We just want to know that we're not alone. We're not just a speck flying through the universe that is alone in our thoughts and our feelings and our experiences. And I think, I'll take that a step further with patients of just, if you can just get down on their level and hear them and listen to them and let them know that they're not alone in what they're feeling and they're not crazy, then they'll loosen up and they'll feel supported. And that's already going to take such a load off of their mental health.
So clearly we've talked about menopause in a person with reproductive organs, okay? Mm-hmm. Female reproductive organs. Men can go through, some people say male menopause. I say late onset hypogonadism, whatever, right? That's what I call it officially. Yeah. So about maybe a year and a half, I've had a couple of friends. I'm almost 44 years old. And I've had some friends, one was like 48, the other one was like 45, who were fatigued. They felt like crap. They didn't feel like they could lift as hard as they once could. They got their testosterone level checked, and it was like lowish. Like, I think one was like 364, the other one was 350. I don't think that's low, but whatever. It's on the lower end of normal. That's fine. So I was like, and I'm a guy, like, whatever. I get morning erections. Like, I'm still like, whatever, horny, whatever you want to call it. I don't care. Like, I love my wife, all that stuff. But I was like, let me check my testosterone level just to be sure.
Yeah.
My level was 234.
Get out.
I swear. And I lift, I run, like I do, like I feel like I get up at 4 o'clock in the morning. I read every day. Like I'm always studying. Like I have energy. I don't feel like I don't have any energy. So my buddy has a clinic very similar to yours. And I was like, let me try some of this testosterone.
Yeah.
Right? So I put it in the fridge and I was going to inject myself with like 50, whatever it was. And I didn't do it. I never did it.
Wait,
so my
why?
buddy that takes it came over and took it. He was like, well, if you ain't going to take the shit, I'm going to take it.
Yeah.
So he came over and he grabbed it and he just took it, right? I didn't take it because I was just like, I don't know. I just felt like I don't need it. Like this guy's clinic that did this. So he, for some reason, I don't know why, he retired and he gave me all his patients. He was like, hey, you can have all my patients. So I have all these men who want their testosterone every month, right? And so I freaked out because one of the guys, I checked his level. It was like over 3,000. His hemoglobin was like
goodness.
19. So one of the things testosterone can do if you take too much of it is it can increase your hemoglobin and it causes polycythemia, which leads to like strokes and heart attacks and stuff. And this guy was like 67 years old and he needed it. His face was like beet red because of his hemoglobin, right? But it was just one of those things where I had this image in my head and I was like, I'm not doing it because I already feel like, you know, like I've got mojo. Like I was like, if I give myself more, like I don't want to, like I don't know what I'm gonna do. I don't want to be like So it's just one of those things where I heard you talk about male replacement. Is that like, do you go by number or are you just like, nah, you got to have some symptoms? I don't think you have any symptoms.
I go by number and symptoms, and a lot of times I have come across men who are in your position where I would look at you and I don't see any of the physical symptoms like hair loss and just looking tired and a little bit more frail and decreased muscle mass. Like you don't present that way, but their testosterone level is a little low. And I find that when I take the time to sit down and go through their day-to-day in life and how they're handling stress and how well rested they feel throughout the day, there comes through some of those symptoms where they really are struggling, but they're those kinds of people. And I think a lot of us in healthcare are these kinds of people where we push through regardless of everything. You do. So you wake up at 4 o'clock in the morning, right? In the morning, do you exercise in the morning? Yeah. Regardless if your kid is sick the night before, you still get up and do your thing.
Yeah.
Yeah. Well, I know your kid was sick last night, right? And you still got here and you came.
I'm still here. No.
Yeah.
I literally did not go to sleep last night and I'm here. Yeah.
So we push through it, right? So it's multifaceted. It's not a one size fits all approach. The same thing with perimenopause and menopause. But with testosterone, you do have to be really careful. And if you're really worried about those risks, of your hemoglobin going up and all the scary side effects that can happen, then maybe an intramuscular injection isn't the right way to go. We can do a topical cream, and the half-life in it isn't as long as intramuscular injections are too. I'm just saying you have options. And then if you're feeling better and if your wife is also feeling better and so your wife's going through menopause, you're going through hypogonadism, and then your daughter's going through puberty.
Oh man.
Oh my God.
Wait, your house?
Yeah.
Yeah.
Oh my goodness.
Yeah, my house.
Hormones.
Right now,
Hormones.
Hormone storm.
What's the probing question you would ask me? Like, what's the probing question? Like, okay, this guy, I mean, seriously, it was 234. This is like 8 months ago.
Yeah, I'd say tell me about what you do day to day. What does the beginning and the end of your day look like on average? And then I'd say, how much sleep are you getting? How much nutrition are you eating? Do you feel tired but wired? Oh, I love that question. Do you feel tired but wired? Meaning that I'm exhausted 24/7, but I'm just like, I'm going because you can't stop. You're tired but wired.
I live in that space.
Yeah.
I would say yes.
I mean, I literally, when you say that, I don't think I've ever heard anybody say it that way. And that is exactly how I feel all the time.
Which can be misdiagnosed as adrenal dysfunction, which I mean, I think all of us have a little bit of, of that to a certain extent, but it can be overlooked as it's this, it's not this.
Right.
It also sounds a little condescending. Can you imagine, like, if her husband's like a little frustrated and she just says, "Babe, are you tired but wired?"
I would like not in shame. I'd be like, yes.
You know what? You're right.
Yeah.
Yeah.
Mm-hmm.
All right, Savannah, like I've given up my testosterone history.
Yeah.
My
Thank you for that.
relationship and my household, I guess. Have you ever spoken about perimenopause or menopause to your mom? I don't know if you have sisters or anything like that, but or cousins or anything like that.
No, so I have a really small family. I don't have any sisters, but when we decided to do this podcast, it dawned on me that I had never had a conversation with my own mother about her experience in menopause. And my mom and I are extremely close. I mean, she taught me about puberty. We talk about everything. And here's this woman who, if I had to think about it, she would tell me all of the things. So it's like, why have I not had this conversation with my own mom about her experience in menopause? So her and I actually sat down just a couple of nights ago. Yeah.
Nice.
And I was like, Mom, what is your story on menopause? When did it happen? Did it happen? Like, I know it did, but, and she told me, she was like, these were the symptoms that I was experiencing. Everything that we discussed, for her situation, it was years and years prior to actual having menopause. I'd say she probably was in perimenopause for up to 10 years. And I go, why would you have never talked to me about that? And she said, because no one ever talked about it. She goes, my mom never talked to me about it. And it was gradual, right? So she said, it wasn't like one day I woke up and I just had these symptoms. She goes, it felt like I reflected back and thought, I think I've been in this for a long time. So we sat down and we kind of went through what she experienced, and it was eye-opening for me because I'm in my debatable mid to late 30s, depending on who asks.
That's not debatable.
So I'm saying that, what's 37?
That's late 30s.
I say I'm late 30s now.
Yeah.
So, you're bringing up a lot of things that for me, we just sitting here having this discussion makes me wonder if, this is going to happen to me sooner than later.
What's your biggest fear of all the symptoms your mom told you? What's your biggest fear?
Oh, that's a good question. They all are, because they all affect you in a different way, right? The mood swings for sure is very concerning. And I oftentimes think about, women who had babies, we go through huge mood shifts, huge. And you're saying that you kind of just know your body and you're going to know that something is different. Well, when you said that, that touches me from when I was pregnant. So I wonder if there's a connection there. But going through the anxiety and the depression that I experienced after my boys were born, it's almost traumatizing to think about having to go through those feelings again at whatever age, whether it's next year or 5 years or 10 years down the line. That's terrifying.
So that's your fear. Your fear is that fluctuation and possible anxiety and depression. Your biggest fear.
That's probably my biggest fear. But then the physical too, if I'm being totally honest, as a woman who loves sexual intercourse and you know what I mean, to think that kind of gets taken away and you don't have control, or you feel like you don't have control. I think a lot of women feel that. They're labeled as, not wanting to have sex anymore, and that they just like reach this age. But men, I have 80, 90-year-old men in my clinic who are like, can I still have sex? Can I still have sex? And we just think that the woman doesn't ever think that way. Right? I mean, yeah. I'm a woman who wants to be able to have sexual intercourse for as long as I can.
Yeah.
And if that's taken away because of symptoms, that scares me.
But it's fixable.
And I love that.
That's the thing.
You're bringing hope to me.
Good.
Yes.
I hope I am, because it is fixable. Low dose vaginal estrogen is the majority of people can do that easily. There's a little bit, there's some debate if there's less risk associated with it because you're not taking it orally, it's topically, and maybe it's not as systemically absorbed and all that, the first pass effect. But it helps. It will help with your sex drive. It will help with that vaginal dryness. It's not FDA approved for helping with decreased libido, but if your vagina is not dry and it doesn't hurt when you're having sex, then the hopes is that your libido will go up and you'll enjoy it more.
Right.
I have to ask a question. Is there low dose estrogen cream that's flavored?
Oh my goodness gracious.
I'm sure we can make it.
I mean, I was going to say, we may have just come up with our next
$1 million idea.
I'm just asking a question. I don't know. New things.
Yeah. But I want to touch on something that you said when you were having this conversation with your mom, that she mentioned it was this long and gradual process. So this is a misconception. A lot of women think that menopause happens when you're old, well, I shouldn't say old, but when you're in your 50s, when you're older. That's not old. Don't clock me for that. And that's not true. So perimenopause can occur up to 7 to 10 years prior to menopause. So the average age of menopause is 51. Okay, so we're looking at somewhere between 45 and 55. So 7 to 10 years prior to that, it's not unheard of for someone in their mid to late 30s or 40s to be going through perimenopause. And like you said, Savannah, it is a long haul thing that happens.
And we didn't bring this up. That's the age when you're 40, 45. What else is going on? So you're starting to have these life changes. Your parents are getting older.
Yep.
They're starting to get sick. They're starting to pass away. I just lost my father-in-law a few weeks ago. Like, your parents are passing away. You might be going through a divorce. You might be, one of your family members may have gotten ill. You're going to move for another. There are all these stresses of life that come together while women are going through perimenopause.
Right.
And I feel like it can have a significant impact on your thought process about life and everything every single day.
Well, it's making me feel like a woman's life is just complicated and a little bit hard. And I'm not lying, because you're saying this and I'm picturing, so I'm 37. I have a 5-year-old and a 3-year-old. I feel like I just got myself out of postpartum. Like, I'm still traumatized by postpartum. It was years and years of like an emotional roller coaster. And now we're talking about being in your late 30s, and then here it all comes again. And to be quite frank, a lot of the things you're saying, I feel like most women are going to hear this and they're going to be like, that's me, or I have a lot of those things. It's a lot.
Seems like a lot.
It is a lot. It is, and it's daunting. But I've said it once and I'll say it again. It's treatable.
Yeah.
It's fixable. Even just like I keep saying, progesterone on its own, you can help with bridge the gap with those symptoms that you're having. So with the feeling anxious or the poor sleep, even though maybe you're not like fully in the throes of perimenopause, you still can treat with progesterone, and it can help stabilize some of those symptoms that you're having.
Do you recommend that women go, if they're listening to this and they're like, this is speaking to me, do you recommend that they go straight to their primary care provider, or do they seek out somebody like you who's highly specialized in this field?
So again, it's kind of a multi-layered answer there. So it depends on your insurance. If you have a HMO, if you have a PPO. So if you have an HMO, you need a referral to see a specialist, to see a gynecologist. So you're going to start with your primary care provider. And based on the clinic, that primary care provider may not be trying to refer you out to people and trying to treat everything in-house, which is a thing that could be another episode within itself. But if you go to them and they're like, no, you're fine, and then the door is closed, you can't get a referral, and they won't listen to you, then the next thing you can do is try a different PCP. And if you keep having stops there and your insurance won't let you go directly to a specialist, then maybe seek out somebody has a cash-based clinic, or someone who specializes it, who's not taking insurance and is, charging a reasonable rate for you. That might be where you need to go.
I think in situations like this, hearing what you had to say, and what I guess to look forward to is, I think you find someone, whoever it is, that you connect with, whether you're connecting online or not, and you pay whatever it costs to go through something like that if you have the means. If you have the means, I think you go through it and you get the support you need, because there's multiple different aspects that they're right. Like, we don't have time to think about on a daily basis, right? We just don't, because you have to see so many people throughout the day. That 15 minutes, you're not going to think about the spouse. You're not going to think about sex. You're not going to think about all these things that you probably should.
Right.
So I think in that matter, the Verve in your clinic, that presence is extremely important in providing that opportunity to encompass everything you should when you're addressing menopause.
Yeah, finding a space like Verve Health is a good start, and finding somebody who's going to give you longer appointment times, who's going to have appropriate follow-ups with you, who's also going to respond directly to your emails and phone calls, and really be able to sit down and know your story and your life and what's working and what's not working, and this integrative approach that is needed in this kind of care. Like you said, Jamie, you might have to just pay for what it is, and it might just have to be what it is going to be, but that's what you might need to do to get the care that you need. And the cost of this varies, right? So there are some places that charge, like a flat rate of somewhere between like $100 or $125 that will give you an annual membership, and then you can pay for the appointments, and then you pay for the medication on the side. So in total, you're looking at a range maybe between like $125 to $300-$400. But some places have payment plans. Some places may even have military discounts or healthcare worker discounts. There are resources out there to get you the help that you need.
And then also, I feel like you have to build a community. I feel like having other women who are going through this either with you or they've gone through it, building that community is key. Do you have any resources, or how are you providing that to your patients?
Yeah, so Facebook groups are great. There's a lot of them, and they're free and accessible. Also, talking to your girlfriends, if you have friends that are around your age, about if they're going through it and how they're feeling, and maybe it's something that they've been wanting to talk about and didn't, so you can be that person to bridge the gap. Also, finding a therapist, which I know is easier said than done, but finding a therapist that will listen to you and help you, and like I said, maybe a female therapist who's gone through it or just knows about it would be helpful. And then finding a provider that will listen to you too.
So to conclude our episode today on the Health Exchange, I think we need to just circle back on the importance of community, on the importance of keeping this conversation going, that it doesn't just stop here. We need to have this conversation in our home. We need to have this conversation with our friends and our family. Spouses need to address this conversation with their partners. It needs to be a safe space. We have to end the stigma of menopause and let this be a place where patients can feel confident and come to providers like Andria with their concerns. We're going to roll into our positive pulse. We like to end each episode on a high note, and Andria has a wonderful story that she's going to share with us.
So I had a patient come in the other week for a consultation, and she came in with this monologue of her symptoms and why she felt like she was in menopause, and I can just tell she was really frustrated and trying to give me all the facts and like lecture me on why she feels like she's going through this transition. And I looked at her and I said, "Hey, I hear you. I see you. What you're going through is real. And I'm sorry that you're having such a hard time with it. And I think you're right. I do think you're going through perimenopause or menopause." And she threw her papers on the floor and looked at me and said, "Thank you." And we shared this moment together. We both got a little teary-eyed. And I think it's just such a good reminder that if we can meet people where they are, if we can listen to them, and if we can have these conversations, then we'll have better outcomes, not only on the healthcare side, but also in our community as well.
Thanks, Andria, for teaching us about perimenopause and menopause today on the Health Exchange podcast. We really appreciate it. Thank you all for watching and listening. Please follow us on Instagram at the Health Exchange Podcast. And if you want to see Andria, where are we going?
You can follow me at the Verve Health on Instagram, or check out my website at vervehealth.me, and you can download my free mini menopause empowerment guide. We also offer virtual consultations and appointments, or you can check us out in person.
And you can get us wherever you get your podcast every Thursday at 9 a.m. Eastern and 6 a.m. Pacific. Thanks for joining the Health Exchange. We'll see you next time.